So these are my consultant disclosures. I'll be talking about anterior approach, and I think there are advantages to it, and the advantages are really the reason for growth of anterior approach. Particularly, I'm aware of this in North America, but also in other parts of the world. The first anterior approach, which I would say was performed similar to what I do, was done in 1947 by Robert Judet, where he used the Judet table to implant his acrylic femoral prosthesis through the anterior approach. And why did Judet choose this? Because the hip is closer to the skin, more superficial with anterior than other approaches. It's an intermuscular approach, preserving muscle attachments. It's an internervous. It follows the internervous plane, so it's a truly extensile approach that allows proximal extension that the posterior or the transgluteal won't. It also preserves the hip deltoid. Now, why did I begin anterior approach in 1996? Because of the classic argument between surgeons. I don't risk of dislocation with posterior approach, why surgeons stay away from it, and the other group stays away from the anterolateral because of the risk of limp for abductor detachment. So for me, it was to do an approach that had neither of these problems. And why do I continue to use anterior approach? Because it had benefits, I would say, essentials of total hip surgical technique, which is preserving musculature, accurate implantation of the prosthesis, restoration of hip biomechanics, meaning center of rotation, leg length, and offset, and also to avoid complications. I operate on the orthopedic table, supine. This is called the HANA table that manipulates the leg. It also operates inside the wound by lifting the femur more anterior for access. And why is the orthopedic table used? Because it facilitates the femoral component through this approach, limits soft tissue trauma while doing it, makes the anterior approach applicable to all patients, and also aids with intraoperative x-ray. Anterior approach, however, is also performed effectively on standard operating room tables. The incision, rather than following the Smith-Peterson line exactly, is over the tensor muscle, over the middle of the tensor, along the posterior half of the tensor in order to avoid the lateral femoral cutaneous nerve. Once we incise the fascia, we can go inside the sheath of the tensor, and your finger can go directly to the hip. So I describe this as the easiest approach to the hip. After you feel the hip, retractors are placed lateral and medial to the hip joint, and the capsule is thereby exposed. So going in this intermuscular interval, after that the capsule is opened, and the capsule is, I preserve the capsule with flaps, and the procedure is done by operating inside the hip capsule. So now we put tag sutures on the capsule, and the retractors go inside the capsule for the total hip. Problems with posterior approach, which is the most common approach, is I would say first is lateral position. Charnley began, Judet began supine because he knew where the pelvis was. And with anterior approach, we have an opportunity to go back supine where we have better cup positioning. Posterior approach is associated with dislocation, I would say also with a frequent increase in leg length and offset. And that's because surgeons try to tighten the soft tissues to prevent dislocation. And for me, posterior approach has been the leader of the drive for the big heads and failed bearing surfaces like Durham and ASR. A soft tissue instability we seek to correct with the prosthesis in the big head. Resistance to dislocation after total hip. We just heard a very good talk about dislocation, but I would say what people talk about are what I call the passive factors: cup orientation, ball size, hip capsule, the resting tissue tension. However, we also need to consider the active resistance to dislocation of the muscular pull of the intact external rotators, and especially the obturator externus muscle, which is on the, or originates from the outer aspect of the obturator foramen, goes to the posterior femur, and has a directly medial pull on the femur. So the short rotators that are important for stability, the gluteal muscles really provide the power, but the short rotators center the ball, stabilize the hip, like the rotator cuff does in the shoulder. Why do I take an x-ray? Because I think the recovery room is film's too late. We want to know the result before the wound's closed. So X-ray, I would emphasize, is not necessary for anterior approach. But what's good is that when the patient is supine and you have a radiolucent table, you can use it very effectively. So I do a preoperative templating as with a normal case. And then intraoperatively, we have the advantage of the patient supine. As the cup is pounded in, as I'm doing it here, we see it on the image intensifier in the rim of the cup, and the ellipse it creates tells us precisely what the inclination and the anteversion of the cup are, so we don't have a postoperative surprise. And the femur, I take images of both the right and left hip. A technique that's very useful is to get permanent prints of both hips and superimpose these to know we've duplicated leg length and offset. Again, we don't have a postoperative surprise on the X-ray. Anterior approach currently, anterior approach has grown steadily over the past, actually 11 years. In 2003, when I held a first course, less than 1% of surgeons used it. A 2014 ACUS survey indicated 25% of surgeons using it, and over 800 surgeons per year in North America received anterior approach instruction at various venues, and this seems to be continuing. So what made anterior approach go? I'd say an interest in improving hip surgery, the orthopedic table helped, surgeon advocates, available education, but this last factor, the patients are very enthusiastic, and we can't doubt the importance of that factor. What about clinical data? When I started teaching this, there was none, but now there's a number of references indicating anterior approach leads to a very low dislocation rate. We recently reviewed a multi-center series of 5,000 cases with 0.2% dislocation rate with multiple surgeons at different hospitals. Anterior approach leads to earlier functional recovery, as indicated by several studies. Anterior approach leads to more accurate acetabular component positioning. I think this is important also in dislocation and wear, supported by several studies. Anterior approach leads to a decreased length of hospital stay. Anterior approach by experienced surgeons has low complication rates. However, by less experienced surgeons may be associated with increased rates of proximal femur fracture. Also, there are references stating that anterior approach, this one notably, does not lead to patient-improved benefits compared to mini posterior. Current problems that exist today that we've talked about today, however, are dislocation, the most common cause for early revision, leg length discrepancy, most common cause for malpractice litigation, and additionally, inconsistent acetabular position. This is a known problem even with expert surgeons. And the primary driving force for this anterior approach is to solve existing problems. Is anterior approach an improvement? I'm saying yes, but this is still a controversial conclusion. However, in 2014, we can say that it's a safe, effective procedure supported by clinical data and publications. Also, I would say that there's growing evidence that anterior approach is solving remaining problems of total hip and improving outcomes, such as solving dislocation problem, leg length discrepancy, and cup position. Thank you.